Hello, everyone, and welcome to today's webinar. My name is Connor. I am the Public Policy Coordinator for the Canadian Cancer Survivor Network. On behalf of CCSN, I'd just like to thank you for attending today's webinar, Why Cancer Still Sucks, and So Does Access to Treatment in Canada, presented by Dr. David Stewart. If you're new to one of our webinars, let me take a moment to give you a brief overview of our organization. The Canadian Cancer Survivor Network is an organization working with cancer patients and survivors to learn about the complexities of our health system, connect with others to plan action, and act on those plans to promote better care and healthier survivorship. If you'd like to learn more about CCSN, please visit our website at www.survivornet.ca. You'll find plenty of information there on us, as well as news, events, and other resources that we think you'll find helpful. I have two quick announcements before I hand things off to our presenter. This webinar is being recorded, and it will be available tomorrow on YouTube. The video link will be sent to the email you provided when registering, so you can still share this resource or go back and watch it again if you would prefer that. At the end of the presentation, we will have a short Q&A session for those in attendance. We will be ending our recording beforehand. However, don't feel the need to wait until the end. Please feel free to type questions into the window at the bottom right of your screen so we can have them queued up. Please keep in mind that Dr. Stewart, for legal and privacy concerns, is not permitted to answer any personal medical questions. But with that said, CCSN is pleased to welcome our presenter, Dr. David J. Stewart, MD. Dr. Stewart trained in medical oncology in the Department of Developmental Therapeutics at MD Anderson Cancer Center in Houston, Texas from 1976 to 1978. He has been on staff at both MD Anderson in Houston and the Ottawa Hospital, where he also served as the head of Division for Medical Oncology from 2011 to 2019. He has published more than 340 peer-reviewed publications. He has published several op-eds in the lay press dealing predominantly with patient access to care, including an opinion piece published in the Ottawa Citizen on June 20th, 2022, entitled "Cancer Sucks, but So Does Canada's Response to It." Now it's my pleasure to pass the floor to Dr. Stewart.
Okay, can you see my slides okay? Okay,
yep, so we're good to go, sir.
Okay, so first of all, I'd like to thank Jackie and Connie and Connor for permitting me to talk to the Canadian Cancer Survivor Network. Trying to get my, okay, these are my disclosures, mandatory for any of us in academia. Just where income comes from, 98.5% from government, 1.3% from consulting for drug companies, 0.1% from a patent that I have a small share in, 0.1% from completing insurance forms. And I will be collecting royalties on the book I'll be discussing, but sharing them with various charities. So this is a book, a short primer on why cancer still sucks. And if any of you are interested in buying it, it can be ordered online from my website, whycancerstillsucks.com, or from Amazon Books. I plan to give a free copy of each book to each Canadian Member of Parliament, Senator, and also Ontario MPPs, as well as to other selected Canadian and US opinion leaders. So the way the book is set up, I won't go into detail on most of it, just in some of the access parts. But I'll give you a little bit on this first chapter, just to give you an idea of what it's about. So the first chapter is dealing with the deluge. Why is cancer so common? As many of you will probably know, that 49% of all Canadian males and 45% of all Canadian females are expected to develop cancer at some point. And cancer is by far a leading cause of death, causing 25 to 30% of all deaths in Canada. And the reason that cancer increases with age is that each of us has about 37 trillion cells in our body, and about 100 billion of those cells divide each day. And there's an average of 3 mutations per cell division. So each of us have about 300 billion mutations occurring in our body each day. Now, the good news is that most are repaired or are unimportant, but some can contribute to cancer. And the more mutations you have, the higher the risk. And the more mutations from getting one day older, but also more mutations from damaging factors. And examples of damaging factors that increase the number of mutations are things like smoking, sun and radiation exposure, even minimal alcohol exposure, processed foods, inflammation or being overweight, beef, veal, and lamb consumption, but not chicken, fish, or pork consumption, and diets are low in fruits and vegetables. And also anything that increases the number of cell divisions per day, just by increasing the number of mutations, can also increase risk. So high calorie intake or being overweight, and any hormones that drive cell division. So if you eat more, there's more insulin and insulin-like growth factors, and that can increase the risk as well, as can other hormones that will increase cell division. The second chapter is looking in depth, so it's about cancer screening. So it discusses why screening does not work better than it does, but why it's nevertheless of value in high-risk people, but perhaps less risk and less value in low-risk people. The third chapter is wasting away, how cancer makes people feel so sick. So this discusses how it causes loss of appetite, weight loss, loss of energy, pain, and other things like that. Chapter 4 talks about surgery and why who can have surgery and who cannot, and why not, and also why the cancer may come back despite surgery that appeared to remove it all. Chapter 5 talks about radiation therapy, how it works, and about its ability to cure some cancers when localized, or to help with control of symptoms in widely metastatic cancers. Magic Potions discusses chemotherapy and hormonal therapy and what are called targeted therapies. And these go through the bloodstream and can reach the cancer anywhere and can thereby prolong useful life expectancy at the same time that they improve symptoms and improve quality of life. This chapter, chapter 7, is about the immune system, how it helps reduce the risk of developing cancer. But if there is a cancer that develops, how new immunotherapy approaches can unleash the immune system to tackle the cancer. Chapter 8 is about how the anti-cancer therapies overall cause side effects and some of the things we can do about those side effects and how our ability to control side effects is improving over time. Chapter 9 is about alternative therapies and why they're alternative. And the bottom line is that they're alternative because they're not proven to be of any value. That does not mean that there's no possibility at all that they will be of value. It's just that the claims that are made for them have not been substantiated by any scientific proof, and many of them really are not of value, but occasionally some are eventually found to be of some value. Oncology myths and legends are things that we think we know but that are not right and that actually mislead us. And chapters 11 to 14 are going to be the major part of the talk today, and they're on issues with access. So issues with drug development, drug approval, drug costs and funding, and also diagnostic and therapy resources. So chapter 11, Mired in the Mud, the high cost of caution, just shows at what the problem is with everything being slowed down, lives lost, and other things like that. Speedbumps on the Autobahn talks about the things that slow progress, the many barriers to progress. Chapter 13, If I Had $1 Million, explains why the cost of doing anti-cancer therapies is rising so rapidly, why it's so high, and why it's rising so rapidly. Ours is Better Than Yours is a comparison of the Canadian versus American healthcare systems, showing the benefits versus the downside of each of the two. And finally, say not the struggle, not availeth, is the future of cancer care and how things are rapidly changing, how things are rapidly progressing, and why the treatment of cancer 10 years from now in many ways will be substantially different than it is now. So let's go back to chapter 11, Mired in the Mud, the high cost of caution. This deals with issues with drug discovery and development. And we did recently published a paper where we looked at 27 different publications in which the new treatment was associated with a statistically significant improvement in life expectancy in patients with metastatic cancers. And we calculated the number of life years lost worldwide per year of delay in getting the drug approved. One life year is one person being alive 1 year. So if a drug prolongs life expectancy by 6 months, for example, that'd be prolongation of 0.5 life years. And we calculated based on the number of people dying from the cancer worldwide. And we calculated that for these different treatments, there was an average of 80,000 life years lost per year per drug. 1 year life year lost for every 7 minutes delay for each of these drugs. Now, from the time from drug discovery to approval for new effective drugs, it takes an average of 12 years to do this if one requires randomized clinical trials. On the other hand, if there's a breakthrough drug designation where one does not need a randomized clinical trial, it may take as well as 4 to 6 years to get the drug approved. But if you look at the number of life years lost from drug discovery until approval for these different examples, there's an average of 1 million life years lost for each drug from the time of drug discovery to approval. Now, when we calculated this, we thought that this would be very interesting to people, and they'd be quite concerned about this high loss of life as a result of delays. But we're quite surprised when we submitted the paper on this for publication that the first 8 journals we submitted to all declined it, and only number 9 accepted it. And the reviews from the reviewers were quite interesting. So, for example, some reviewers said the losses are so huge that this cannot possibly be true. But anybody with can access the data that we use to calculate this, and they're very real. Other reviewers said it makes no difference since we cannot fix a problem, even if we know about it. And still others said it makes no difference since so few patients worldwide would even be able to afford them, even if they were approved. So we don't need to know this information. So this was quite surprising and concerning to us. We also submitted op-eds to various newspapers, and several were submitted and declined by the papers until the Globe and Mail finally did accept it. But we were quite surprised again that there was absolutely no reaction to this. So Joseph Stalin once said, if one man dies, it's a tragedy. When thousands die, it's statistic. And this is what the problem is. We have become numb to the problem that with all these excess deaths as a result of these delays in approval of effective new drugs. So if any of you have driven on the Autobahn in Germany, it has large sections with unlimited speed limits where if your car can go 140 miles an hour, you can drive 140 miles an hour. And yet it has one of the lowest traffic fatality rates in Europe. And the reason for that is that they have very smart regulation that makes things safe despite the very high speeds. And but there are many speed bumps on the Autobahn for clinical research. So there have been numerous problems with clinical research and new drug development over the years. Problems with ethics, human rights, safety, and data integrity. And therefore, these speed bumps are very, very important. Regulation is absolutely essential. But the thousands of speed bumps on the research highway have markedly slow progress. This greatly increases the cost of developing a drug. And if it costs a lot to get the drug developed, then the drug company has to charge a lot for it when it's approved to recoup those costs. And it also costs thousands of lives due to delays in access to these effective new drugs. So there has been very little attempt to quantitate the costs of these speed bumps or to consider more efficient, less costly alternatives, like on the Autobahn in Germany, where they came up with alternative regulations that keep the drivers very safe despite the very high speeds. So this chapter is a call to action on problems and their alternatives. To put this in perspective, we need to consider COVID. 1.1% of Canadians affected by COVID died from it. In comparison, 37% of Canadians who develop cancer will die from it on average. Since January 2020, when the pandemic began, about 41,600 Canadians have died from COVID. This is a horrific number. At the same time, over that same time period, 200,000 Canadians have died from cancer, an even more horrific number. Because of the stress in developing rapid COVID vaccines and making the regulations fit so that this could be done, it only took 1 year to develop effective COVID vaccines, but it takes 12 years to develop effective new drugs for deadly cancers. If it only takes 1 year to develop a COVID vaccine, then cancer drug development should be much, much faster than it is. There should be lots of ways to do this. And so the regulatory framework must change. The next chapter is If I Had $1 Million, the explosion of cancer therapy costs. Now, over the past few years, more and more effective new drugs have become available. This is very exciting, the rate at which new effective drugs are being developed. This is changing our present and our future. But these drugs are fairly expensive. So in 2012, in the United States, it cost a median of $90,000 per drug for a year of treatment with these new anti-cancer drugs. By 2016 to 2017, this price had doubled to almost $180,000. So these are very, very expensive. That's for 1 year of treatment. So why are the costs going up so fast? Well, drug development costs, as I said, are going up very fast because of the speed bumps. They're rising much faster than inflation, and a company must be able to recoup the cost of drug development when they sell the drug. And so if the cost of development is going up, then the cost of selling the drug also has to go up. So it cost an average of $4 million to develop a new anti-cancer drug in 1962. This would increase to $231 million by 1987 and to $2.9 billion by 2013. So more than a tenfold increase from 1987 to 2013. These costs reduce competition because it means only large companies can compete. So that reduces competition and further increases the problem. Also, there's short patent protection. So most drugs have a patent protection of 20 years. But if it takes 12 years to develop the drug before they can market it and sell it, then they have to recoup the cost of drug development in just 8 years, so the price has to be very high. There's also a very high failure rate. Of all the anti-cancer drugs coming into clinical trials, 92 to 97% of them never make it. They're discarded. So the cost of these failures has to be recouped from the cost of from the profits on the successes. If there is no way to recoup the cost of these failures, then research would grind to a halt because no company would dare to try it if they were not going to be able to recoup the cost of their failures. There's also been personalization of therapies. So 20 years ago, if I wanted to treat one cancer patient, I could use the same drugs to treat them all. But then with personalization, we found that a new drug might only work in the 1% of patients that had, for example, a ROS1 fusion gene. And so the cost of developing a drug to hit that 1% is the same as for hitting all of them, but the number of patients that we can recoup the cost from through profits is much, much, much lower. So the cost per patient has to be much higher. There's also what we describe in Chapter 13 as distortional market forces. This is just how different drug companies play the game and thereby can force up prices in other ways. And we'll discuss in the chapter how these can be tackled as well. And then there's that dirty word, profits, pharmaceutical company profits. And the pharmaceutical profits are higher than most other industries. So one can say that's bad because those high profits, they help drive high prices. On the other hand, it's a double-edged sword because those high profits also directly drive investment. So if your pension plan wants to have lots of money to pay you a nice pension when you retire, they're going to invest in industries that show good profits. And the pharmaceutical companies do that, so it leads to high investment. That investment in turn, that money coming in investment, that's what drives the research that permits more progress, and that's what gives the rapid progress. So those high profits are directly responsible for this rapid emergence of effective new drugs. And if you're wondering about who invests in them for profit, if any of you are collecting from the Canada Pension Plan, well, the Canada Pension Plan invests heavily in pharmaceutical companies. So some of your check each month that you get from them is coming from pharmaceutical companies. So we need to find solutions to high prices that do not gut the profits that drive programs. So as far as the solutions, there are two major camps. One is government price regulations or government price controls. The other is to restore market forces. So the problem with government price controls is that they usually fail, and many economists tell us this, and they fail by creating shortages. If you cut the price that the company can charge, then they stop producing and selling as much, and then that creates shortages, so then that drives up the price. And also there are end runs and special considerations. So there's evidence that this happened, for example, with COVID-19 vaccines in Canada, that to escape the future government price regulations, they actually negotiated a sweetheart deal that none of us are permitted to learn anything about, but they would have driven up the prices of those vaccines. And then Chapter 13 also talks about different ways to restore market forces. My take on it, though, is that we must start first by drastically reducing the cost of new drug development. If we can, and there should be lots of room to do this because there's a huge amount of waste there, but they should give room to cut prices without eradicating the profits that drive investment and progress. And this will also increase competition if many small companies can compete because it now costs far less to develop a new drug. So in Chapter 14, again, I talk about the Canadian versus US healthcare system. The United States has by far the most expensive healthcare system in the world, but despite that, their average life expectancy ranks 46th in the world, just ahead of Albania. So why is that? Well, one of the problems is that when you turn age 65 in the United States, you get Medicare, and that's gold-plated insurance. That's fantastic insurance. But if you're under the age of 65, you may have no insurance at all. And if underinsured or uninsured young people may die of preventable causes that they would not have died from in Canada. And the United States has one of the highest maternal death rates and highest infant death rates in the Western world. But also Americans die of other things at a higher rate than Canadians as well. For example, the probability of driving in a traffic accident in the United States is about twice as high as it is in Canada. Drug overdoses, the risk of death, also much higher in the United States. Homicides, an American is 5 times more likely to be murdered as a Canadian. And also, an American is 6 times more likely to go to prison than a Canadian, because the United States has the highest imprisonment rate in the world, and being in prison takes an average of 5 years off your life expectancy. So if we look at Canada, Canada has the 11th most expensive healthcare system in the world. So in 1985 to 1995, we ranked 7th internationally. But by 2020, we dropped to 16th. It's projected that by 2040 that we'll drop to 27th because of issues with our healthcare system and with other issues. So, for example, the wait time for elective surgery is much longer in Canada than other comparable countries such as the United States, United Kingdom, France, and Germany. When it comes to cancer, the 5-year relative survival rate, 67% of Americans who develop cancer are still alive and doing well at 5 years. It's higher in whites, where it's 68%, compared to African Americans, where it's 63%. The average Canadian is 63%, the same as an African American. And this isn't something that just happens 1 year. Consistently, year after year, the probability of surviving cancer is higher on average in Americans than Canadians. If you look at by income of the individuals, the poorest Canadians do better than the poorest Americans, but people in middle and higher income groups do better in the United States. If the average Canadian had the same access to rapid diagnosis and treatment as the average American, about 9,000 of the 84,600 Canadians who died of cancer in 2021 might have survived. So we've already talked about drug development and clinical trials impairing drug access. So also, when does a company apply to a country? If they don't apply to your country until long after other countries, then you'll have reduced access. And how rapidly a company applies will depend on how much the country is willing to pay for the drug and the size of the market. The bigger the market, the earlier they'll apply. It's very expensive to a company to apply to countries, for example, about $500,000 or so to apply to Canada, 2.9 million or so to apply to the United States. And then it also varies in how long does it take for the country to review applications, and then how long does it take for the company to then start marketing the drug after the country approves it, and then how long does it take for the country to start paying for the drug or public reimbursement, and then also how long does it take for diagnosis and treatment, because we have to know how wide the cancer spread before we can start the treatment. So this is just average prices paid. So the red bar is Canada pegged at 1 to show the relative prices, and this shows that the United States on average pays 3.5 times as much for a drug as Canada does. Most of the European countries are just above Canada to just a bit below them, and then down at the bottom end is Turkey that pays only 30% as much for a drug as Canada does. So that because Canada is willing to pay a lot, then companies typically apply to Canada a lot earlier than other countries. So that on average, drugs are approved in Canada, if the drug company applies at all in Canada, about 1.2 years after they're approved in the United States. So on average, the companies apply to Health Canada about 10 months after the United States and 8 months after the European Medicines Agency. And if we look at what drives where the company wants to apply first, so the U.S. In the U.S. it takes about 10.6 months for the FDA to review the application. They've got 330 million people, a very large market, and they pay the world's highest drug prices. The European Medicine Agency takes an average of 12 months to review the application. They have 500 million people, and some countries pay the same or higher prices than Canada. In Canada, it takes about 12.9 months for Health Canada to review it, so they do a decent job. And we've got 35 million people, and typically have been willing to pay very high prices. So overall, it means that Health Canada, on average, has the 4th highest approval in the world, and this permits a drug purchase out of pocket by insurance. So as soon as Health Canada approves it and the drug gets launched, then if you've got good insurance, you can access it. But it does not come with public funding. However, only about 66% of all drugs that are marketed worldwide are marketed in Canada because companies in many cases will decide that it's not worth it to come to Canada at all. And so that we lose something here because they're effective drugs that the companies never even come to Canada to try to market them. So on average, Health Canada comes up with approval 248 days after first global approval, with launch in Canada 119 days later. So that's a total of 365 days, or 1 year from earliest access in the United States until there's access in Canada if you've got private insurance and want to pay out of pocket. However, it's another 1.5 years on average before there's public reimbursement in Canada. So Canada does the third worst of any of these countries. So the only countries worse than us were New Zealand and Portugal when it comes to public reimbursement. And again, this is the only way that many Canadians can access these drugs. If you look at both the number of drugs launched and public access, and Canada compared to these other countries, Canada ranked 14th out of 19 in these drugs and these countries with respect to new cancer drugs launched and reimbursed through the public system between 2011 and 2020. So that's not very good to be ranked 14th out of 19. Now here what we did was we took the data and we plotted the probability of the days to public funding against the how much countries paid. Number 30th down the far right, well, that's the country that paid the highest amount. And so the more the countries want to pay, the shorter the time to public funding. So over 1,000 days for some countries down to just a couple hundred days for other countries. But this graph is missing two countries. The two countries it's missing are Canada and New Zealand. They're outliers. Despite paying a lot, they have very slow access to public funding. So this can suggest that there's a fundamental problem in Canada's approach to public funding of drugs. A couple of years ago, Joanna Godfrey from our group published this study on a number of life years lost in Canada while waiting for public funding. So these are drugs that can meaningfully prolong life expectancy and alleviate suffering in patients with cancer. But thousands of Canadians may suffer unnecessarily because they cannot get access to the drugs because they're not publicly funded. And thousands of Canadian life years may be lost during these delays as well. So as far as what's happened during that time period, for the public funding, the drug undergoes what's called the health technology assessment after Health Canada approves it, and Health Canada does a good job, but then it goes to this group, Canadian Agency for Drugs and Technologies in Health, or CADA. They review it, and if they approve it, then they will either approve it or not, but then they will recommend a price. And recently they've been recommending a price of $50,000 or less for quality adjusted life years gained. So that means that the number of how much the drug costs to treat the patient, that it has to be $50,000 or less for life year gain, and that with the quality adjusted. So if you're a bit sick during that time period, then that's not quality adjusted, that's not good. If you're feeling well, then it is. So then that drug is passed on to the Pan-Canadian Pharmaceutical Alliance, which negotiates a price with the company on behalf of the federal government and the provinces. After that, it's then passed on to the provinces for further price negotiations between individual provinces and the company. So in 2013 to 2015, this entire process from it being submitted to CADA until it being approved by the provinces was an average of about 1.5 years. But by 2016 to 2017, that had increased to 670 days. So this was 51 days from the time it's approved by Health Canada until the company applies to CADA, another 7 months while CADA reviews it, another 5 months before PCPA will even talk to the drug company before beginning to evaluate the drug, before beginning to negotiate with them, another 7.5 months before the PCPA and the company are able to reach an agreement, and then another 22 days for the average province to pick it up after that. Now, it's important to recognize that most people who work for CADA and PCPA will have private drug insurance paid for through their work, so they'll probably pay the premiums themselves, but they'll get a discount rate based on them being a public employee. And so they'll get access as soon as the drug is launched after Health Canada approval for them and their spouses and their dependents. But then they'll be negotiating on behalf of the public that don't have that, and it'll take them another year and a half to negotiate this on behalf of the people that are depending on them when they themselves are not suffering this pain. So CADIF is now demanding 50% or greater reductions in drug prices on 49 out of 61 new drugs that they approved between 2020 and 2021. That's a very large price reduction, and for some drugs it was greater than a 9% reduction in price that we're demanding. And this was using the threshold of $50,000 per quality adjusted life year. Now, measurement of life years itself can be problematic because of the way clinical trials are done. For example, if patients cross over from the old drug to a new one, then that diminishes the apparent benefit of the new drug. But also the quality associated part is very subjective and can be subject to a lot of biases. So it's not a very accurate measurement. The other thing is that CADIF recently really started pushing this $50,000 per quality adjusted life year. But it's interesting that they got this from 1975 when it was exactly the same $50,000 per quality adjusted life year. But the only thing is that $2022 is worth 5 times more than $1975. So in effect, CADIF has devalued a Canadian life by 80% compared to what it was in 1975. Now, if CADIF is demanding a high reduction in price, then it takes longer for PCPA to negotiate with the drug company, quite a bit longer. So this leads to delays if CADIF is demanding a high reduction in price. So why are these things happening? Well, in the 2015 election, the Liberals promised Canadians lower drug prices. But the cost of lower drug prices, unfortunately, is reduced access to effective new drugs. So with this, the government instructed CADIF that they had to demand bigger price reductions for the drugs. So starting in 2019, the proportion of drugs in which big price reduction was demanded jumped very substantially. So the provincial government funding cannot move faster than federal level institutions like CADIF and PCPA. However, a PCPA member once very recently said to one of my colleagues, "Why are you oncologists always in such a rush anyway? You shouldn't be in such a rush to get these drugs approved." Well, we're in a rush because we're trying desperately to alleviate our patients' suffering and to save their lives. The CADIF and PCPA don't seem to get that. In my opinion, this is a problem with leadership at the highest levels. Also adding to this is the Patent and Medicine Prices Review Board. So Canada has a Kafkaesque situation of having 2 different government bodies looking at pricing. So it's the second player in regulating Canadian drug prices, and they set a maximum price a company can charge for a drug. So in 2017, they proposed new regulations to reduce prices, and they mandated an initial price reduction of about 20%. And then they said that if sales were good, then the price would have to come down a lot lower, as low as a 50 to 80% reduction in the price of the drug as sales increase. So this creates uncertainty for companies. Companies don't like uncertainty, and so a lot of companies started threatening not to apply to Canada as well. And it was this type of thing that the government had to promise the Pfizer they would not do if Pfizer agreed to bring COVID vaccine to Canada. So in their 2020 presentation to the public to justify that, so the Patent and Medicine Price Review Board pointed out that there had been a marked increase in the size and the cost of patented drugs. So between 2013 and 2017, the price of patented drugs had jumped markedly. The only problem that what they didn't say was that their own data. This is their annual report from 2019 is that 2013 was the year where the drug prices were lowest since 2002 as a percent of gross domestic product, and 2017 was the year after that they were highest, and then they came down again. So that 2019 was actually lower than 2002. So drug prices are high, no question about it. But the PMPRB's presentation, I personally felt was misleading. In that same presentation, another slide, they said countries with lower patented drug prices than Canada may have greater drug availability of new medicines than Canada does. That sounds pretty tempting. You can bring down the price and also increase your availability at the same time. But the intent appeared to be to make the point that reducing Canadian prices would not negatively impact drug access. My personal feeling is that this is wishful access. I took the data from that slide and I just replotted it, plotting the percent of drugs available versus the relative price. And so for the European group, a very highly significant association. So the more a country is willing to pay, the higher the proportion of drugs that they get access to. And here's the other countries outside the EMA. Again, same thing. The higher the country is willing to pay, the higher the proportion of drugs that they get access to. So, and when we looked at it and looked at their data and said, well, what will happen if they force Canada to drop the price of its drugs by 20%? That suggests to me that that will decrease Canada from having access to an average of 48% of the drugs that the rest of the world has, down to about 35 to 39%. So I think that this will that there's a very high risk that this would worsen access of Canadians. So in my opinion, Canada's huge error is that CADID and PNPRB try to force price down while ignoring access. And this will worsen Canada's already impaired access because countries will be less incentivized to apply to Health Canada in the initially, and also it will worsen the ability of PCPA to negotiate prices for access on behalf of the provinces. We instead need to concentrate on improving access while looking at innovative approaches to cost control. Okay, the last part of this is how long does it take for diagnosis and treatment initiation? For diagnosis and treatment, you have to have a lot of scans done, first of all, to find the cancer and then to see how far it's spread. So the OECD is the Organization of Economic Cooperation and Development, so the richest countries in the world. And out of the 33 that provided access on CAT scanners, Canada ranked 30th out of the 33 with a number of CAT scanners per million population. So behind those healthcare giants, Turkey and Chile and Greece and all of Eastern Europe. Here's MRI scanners. Again, we ranked 26 out of the 31 countries reporting, again behind Turkey and much of the Eastern Europe. Here's hospital beds per 1,000 population. We ranked 30th out of 37. You wondered why all those elderly people died of COVID in those nasty nursing homes? This is the answer right here. There were no hospital beds to transfer them to. Radiotherapy machines per million population. Canada ranked 27th out of 29 OECD countries. Specialists, medical specialists in Canada. Canada ranked 31st out of 34 countries in access to medical specialists. So if it takes too long to diagnose and initiate treatment, this has a negative impact. So this is a publication on the risk of death per week, of how it increases every week of delay for early stage cancer that are potentially curable. So that every week of delay, there's a 1% or more increase in the risk of dying from that cancer eventually for breast cancer, lung cancer, pancreatic, and kidney cancer. So rapid access to treatment is very important, and these delays that are built into our system are not good. If a patient has metastatic non-small cell lung cancer, they're in trouble. They've got an average life expectancy of about 4.5 months. But if we give them chemotherapy, it can markedly improve how they feel, and it can increase life expectancy to 1.5 years or more with a good quality of life. But for every week that goes by that we don't get them on treatment, 4% of remaining patients die for every week we cannot get them on treatment. And many of the people that are still alive at the end of that week, many of them will have deteriorated, so they're now so sick that they're just too sick even to consider treatment. And it takes weeks for biopsy staging and molecular testing, and it takes much too long in the Canadian system. So this is the reason that in Ontario, despite treatment for non-small cell lung cancer being fully funded, only 25% of patients with metastatic disease ever make it onto treatment. It takes too long. So this is the probability of surviving cancer. So Canada does not too badly compared to other countries, but not nearly as good as others. So the green bar here is the United States, the red bar is Canada. And again, so about 4% of people that would have survived cancer in the United States die from it in Canada. So that means that of the 84,600 Canadians who died from cancer in 2021, about 9,000 might have survived if they had the same access to diagnosis and treatment as the average American. We can multiply that 4% by the entire number of people who develop cancer in Canada. So this just shows that the more CAT scanners that are available, the higher the probability of surviving cancer. And here's drug access. Again, improved drug access is associated with increased survival of cancer. So as far as the solution, the number one issue by far is that we need to prioritize access. Cost is important. All these things are important, but we need to prioritize access, not just cost or safety or ideology. If you're putting a new seatbelt in your car and you wouldn't go for the cheapest one if it did not meet the minimal standards for safety. The same for the smoke detector in our house. You would not go for the cheapest one if it did not meet the minimal standard for safety. Or buying life jackets for your grandchildren. You just wouldn't do that. You want to make sure that you're getting value for money. So as I see it, this is a problem of leadership that starts at the highest political and public servant levels of Canadian federal government. As I said, Health Canada itself is good, but the other health branches of the Canadian government, not so good at all. So again, if you want to read more on this, again, this is my book, and you can access it online at my website, whycancerstillsucks.com, or through Amazon Books. And okay, thank you very much.
Alrighty, well, thank you very much, Dr. Stewart. So we will just have a few questions, and once we finish with them, we will wrap up this presentation. All right, so first question, how do medical authorities keep track of adverse consequences of drugs such as, pardon me, I'm gonna have to spell this out, IDELALISIB, which are approved with strong warnings about possibly fatal consequences?
Yeah, in fact, all of our anti-cancer drugs, or almost all of them, have strong warnings about that. The way they do it is that there's a monitoring system so that if there's anything unexpected, then the government Health Canada is supposed to be notified of that, so they can keep track of that. At the same time, that all the countries internationally are keeping track of it, so that we can spot it. All of us as practitioners are watching for anything that's unexpected that may be there that had not been seen before, that we can warn others about. So that's our job as oncologists. We deal with toxic therapies. It's our job to try to make sure that our patients are safe to the extent possible while we're giving those drugs to them.
All right, next question. Incredible statistics, but how do we connect the individual tragedies to these that can affect change?
Well, in fact, that's a huge problem, is that any one patient who dies from cancer, that could have happened anyway, no matter how good the prognosis, some patients are still going to die. So you can't say that it was due to a problem with access. And so this is the huge problem. All the individual stories that are there, all the individual people that have suffered and died who could have been helped by these drugs. And the huge problem is that most people do not understand what the problems are until they're in the system. They think that everything is fine, that everything's going to work well. They don't understand how that there are effective drugs available in the United States and elsewhere that we try hard to get access, but often we cannot. We just can't. These are drugs that could have helped them, but we cannot get access.
Alrighty. Next question. Are those figures and tables in the book?
No, not necessarily. So some of them are, and some of them aren't. So that very few of the figures are. They did not put any figures at all in the book, but a couple of the tables are. But again, the slides from this presentation are available. So they round out. So the book does go into a lot more background information and a lot more of the nuances on how these things happen and why. But actually, the slides from this presentation would complement what's in the book.
Alrighty. Next question is, what about access to family doctors in Canada?
So there's been in the news a lot recently about the shortage of family doctors. The interesting thing, all those figures I showed you on the OECD, Canada does not do badly there from family doctors. So they're about just between the upper third and the middle third. So not too bad. The huge problem in Canada with family doctors is a compensation model. Family doctors are strongly disincentivized from seeing patients in their office because every patient they see in their office, they're paying 30 or 40% overhead. Whereas if they get a job in an emergency room or covering a retirement home or something like that, no overhead. And also with the shortage of specialists in Canada. That means that the family doctors are doing some of the work that specialists would do, so they're not available for the family medicine type things, and also they're made inefficient because they don't have the backup to try to get support from specialists than they could in other countries because there are not enough specialists.
Alrighty. Is there another system that might work better to give patients better access without markedly driving up costs?
So the short answer is I'm not an expert in that, and I can't say for sure. But I've heard very good things about the systems in Germany and France and some of the other European systems. I heard very bad things about the United Kingdom system for a long time, but I'm starting to hear more good things about it now. So I think so there are ways of solving the problem. All we need to do is decide what our priorities are. As long as we keep concentrating on the costs, driving down costs are our priority, we are not going to get things better. We are just going to get worse access without a great improvement in cost. But if we really want to look at where we want to be as far as the optimal access with affordable costs, then we've got to do it that way, and we'll find lots of examples in other countries. Like I know for sure that the American system itself is not the way to do it, and you'll see in the book why that is. And the basic thing is that there are far too many administrative costs in the healthcare system because of the insurance companies that markedly drive up costs in the US system without adding value.
All right. So how do you feel about the importance of the role of drug access navigators? Do you feel they increase patients' access to drugs?
Yes, absolutely they do. So that, for example, we've got a reimbursement office here that's been operating now for the past 20 or 30 years. That's very, very important. So it means that if a patient has insurance, for example, we'll be able to help them get access to the drug. So say a drug costs $10,000 per month, and the patient has a insurance that covers 80%. That extra $2,000 per month is still a huge amount. Many patients can't afford that. So the reimbursement specialists and navigators can help negotiate with the drug company to get that copay waived so that they can actually get access. The same with getting free access from companies. Not infrequently, we can get free access for some of these drugs from some companies. So they're very, very, very important.
Alrighty. So in your view, what should CADTH be doing to help improve the HTA process to enable faster access for Canadians to drugs?
We get rid of CADTH completely because Health Canada has already looked at the value of the drug. We get rid of CADTH completely. It does not add value, nor does the patent, the PRB add value. They just do not add any value. They add complexity, they add time. They do not, in my opinion, they do not add value.
All right. So with the shortage of CT scanners, MRI scanners, and other resources in Canada, why is there not an even greater impact on probability of surviving cancer right now?
Because of efficiency. So that if you look at the number of hours per day that a CAT scanner or MRI scanner in Canada runs, it's more than just about anywhere else in the world. I mean, there are times that our MRI scanners are running 24 hours a day. So that the high efficiency does make a difference. But then all that has to happen is for one to break, and suddenly you're in deep trouble because then you've got nothing, and you don't have any backup because you're relying on just that one scanner. And so in Canada, in fact, I've taken part in many exercises in how to try to make things more efficient, to try to tweak the system to make things faster. So we were able to get down very markedly the time from diagnosis until initiation of treatment for patients with metastatic lung cancer, for example, just by looking carefully. But it took a large number of people meeting once a week for a year, looking at all the processes in the system to do this. But these types of things, we put a very high priority on this. And Dr. Michael Funky Fung from here in Ottawa is a world expert in these types of things. I'm trying to drive efficiencies and to try to get the maximum out of the system. And so that if we did not have those, we'd be in even much worse shape than we are.
All right. So finally, do patients understand the difficulty in accessing new therapies?
No, almost none of them do until they're looking down the gun barrel. They just have no idea that it could possibly be this bad. They just don't have any idea.
All righty. Well, with that, I'd like to thank everybody for attending our webinar today. CCSM would, of course, like to thank Dr. Stewart for a very insightful presentation, for all the work that you do for the cancer community. For everyone else, this is one of a series of webinars we have planned for 2022. Registration information for our next webinar will be out soon, So watch your inboxes and social media feeds for that. A quick note about email. If you're not seeing our emails in your inbox, please check your spam or junk folder. We use a third-party email service, so please check your spam folder and mark emails from CCSN as safe, or add us to your contacts list to ensure they'll come straight to your inbox. If you'd like to purchase Dr. Stewart's book, it is available through Amazon Books or through his website, www.whycancerstillsucks.com. As always, all our previous webinars are accessible on demand through our website, www.survivornet.ca/webinars. Thank you again for attending, and everyone, please enjoy your day.